Okay, I think we have about 50 participants. So I think I'm going to go ahead and start. I'm sure some people will join us a little later. I think because we only have 50, I'm going to skip the poll and maybe come back to it if we have time, if we have a larger audience. So welcome to our regular season of Grand Rounds. The summer frequency is over, and from this week on, we'll go back to our weekly Grand Rounds with a case conference in the beginning, and then a department meeting and resident case conference as the fourth Grand Rounds, and then 2 other regular sessions in between. We've been talking about bringing in some visiting speakers. There's pros and cons of doing that. Those would be by Zoom, so in some ways easier to bring people. They don't have to come here physically, but then we don't get the same kinds of interactions with them either. So we'll have to decide how much we want to do that and what kind of people would best be brought in that way as visitors. So once again, for those of you who have not done this frequently, the audience is muted and you cannot turn your video on. The way to ask questions is to use the Q&A button at the bottom of your screen. The panelists will be able to see the questions and respond to them appropriately. So do ask questions throughout the presentation if you want. We probably won't get to answering them until the very end. So with that, we now have 64 participants. I'm going to pass it over to Dr. Lori Lerner to introduce the topic and the other speakers.
Hi, thanks Dr. Patak. Thanks for having us. This is our case conference. Happy first day of school to everyone. Let me share my screen. I think about 3 or 4 years ago, I did a grand rounds on lung cancer screening and presented all the data at that time. And now in 2020, I want to do a update since there's been some updates to the U.S. Preventive Service Task Force, and then also try to address from a 10,000-foot view some of the most frequent questions that I've received, mostly about harms of lung cancer screening, and then look at some of the RGH data that we have out of the lung cancer screening program. And then Dr. Bhaskar is going to present some exciting information about new technologies that are coming our way at RRH with an emphasis on how they might also prevent harms. And then Dr. Liang is here from cardiothoracic surgery to also present questions or a topic of surgical resection with an emphasis on how to prevent harms. So let's see, trying to advance. So case presentation. 53-year-old man presents for his annual visit. He's feeling well, but with mild shortness of breath, some dyspnea on exertion, chronic cough, otherwise doing well. He's been a 1 pack per day smoker for 25 years. He quit 5 years ago. He was employed on a road paving crew, so some occupational exposures, no personal history of malignancy. His mother was a smoker. She did have lung cancer that died at the age of 63. He has mild emphysema on his CT scan done in the ED after an MVA. So clinical question number 1, is this patient eligible for lung cancer screening? So the answer to that is in 2013, no, he would not have been. Under our current guidelines that came out in 13, age is 55 to 80, 30 pack years, and less than 15 years since he quit. Now, the U.S. Preventive Services Task Force has a proposed change in 2020 to reduce the age of starting to 50 and only 20 pack years of smoking. And the 15 years since quitting is going to be stable. Now, these aren't officially in place yet. It's just a proposal from U.S. Preventive Services, and it will probably in the next month or so be finalized. And then, of course, we have to wait for payment from CMS. So stand by. We're thinking this is going to happen. So clinical question number 2. So what data supports this? Why are we making changes? And again, what we've seen in the last few years is originally we had the National Lung Screening Trial. It was 53,000 patients, and it showed a reduction in all-cause mortality as well as lung cancer-related mortality. But that was the only trial. So since then, we've had long-term follow-up, another 7 to 9 years of follow-up of the NLST data, as well as Nelson. So Nelson trial is the Dutch trial. It screened 15,000 patients compared just to no screening as opposed to X-ray in the NLST. They had a little bit different structure. They screened at baseline 1, 3, and 5 years as opposed to 1, 2, and 3 years, then 7 years of follow-up. Anyway, what they showed is reduction in lung cancer mortality. They did not show reduction in all-cause mortality, but their number needed to screen was only 130, pretty good, as opposed to NLST number needed to screen of 323. So another large trial came out, really precipitated this look at the data. So we look at what are we going to end up with these new guidelines, and how is it going to change our statistics? So currently, under our current guidelines, about 14% of the population is eligible for screening. That's predicted to go to 20 to 23%. That's a lot of screening. The estimated lung cancer deaths prevented per 10,000 people screened will go from 38 to 47 to 56 in these models. Similar for life years gained, go from 488 to 604 or 602 to 760. Pretty robust numbers, in my opinion. And then there is a downside. So the last 3 false positives, small increase in false positives per person screened. Overdiagnosis, which we'll talk about more, also is increased with the new guidelines. And then radiation deaths, a small increase as well due to increased radiation exposure. So back to the case presentation. The PCP thinks to herself, she says, there are so many indolent and insignificant nodules. How do I know I'm not putting this patient in harm's way, only to find a cancer that would never become clinically important? So what is that question? So the clinical question there is, does screening lead to overdiagnosis of cancer? And the answer is, just to review overdiagnosis in this cartoon. So you look at the 2 timelines. If you imagine that these are 2 potential trajectories, if a cancer is going to be diagnosed here after someone dies of a natural death, as opposed to diagnosed by screening, of course, this would never have become clinically apparent if we had not been screening. So that's overdiagnosis. So the answer to this question of overdiagnosis, I think, is best when we look at this table. So the most important thing to look at here is we have the NLST trial in the top row, and then the follow-up data, so additional 7 to 9 years of follow-up in the National Lung Screening Trial. And then we also have the Nelson trial at the bottom, and those are the ones I'm going to emphasize because those are really the largest, most well-designed trials. So here we see in G1 is the number of cancer diagnoses in the screening group, and G2 is the number of cancer diagnoses in the control group, and there's a significant difference. So at time 1, or basically when NLST was published, there was more diagnoses in the screening group, so significant overdiagnosis. But what we see is that when we follow these cases out an additional 9 years, that difference falls away and there's no significant difference. So the message is that if you follow these long enough, chances are the overdiagnosis becomes a much smaller number because those indolent cancers do become apparent. And so when you summarize this, again, what we see is at 11 years, there's no difference. And then a similar signal in the Nelson trial that when we look at 10 years out in the Nelson trial, there's 40 excess cancers. But if you follow just a single year farther, there's only 14 extra cancers. So those, there's a catch-up signal somewhere around 10 or 11 years. So if you take this in bulk, what we estimate is under the 2020 guidelines, per 100,000 people screened, there'll probably be 83 to 94 overdiagnoses of cancer. I think that's probably tolerable, in my opinion. In the 2013 guidelines, it would have been 69 per 100,000. So again, we do have a little bit more overdiagnosis, but I think those numbers aren't horrible. So back to the case presentation. The patient ponders the utility of screening. He says, you know, doc, I've smoked for years and I know I might get cancer and I'm okay with that. I don't want to know, it's not curable anyway. I think we've all heard patients say that. So how do we respond to that? And what's the clinical question here? So does screening lead to a stage shift in cancers diagnosed? And does screening lead to either all-cause or cancer-related mortality? And sorry, this is a little bit fuzzy, but what this table is answering is, does screening lead to a stage shift in cancers diagnosed? And indeed it does. So this side of the chart, what we're looking at, again in NLST and Nelson, is that actually in every trial, there's a significant increase in the early stage. So this is looking at early stage cancers in control and intervention group. But what's interesting is there's not as much of a signal as far as less late cancers being diagnosed. It is significant in the NLST, but it's not as robust. And I think part of this is the overdiagnosis signal, in that we're finding more of these early stages and not necessarily as much less of the late cancers. All right, so to look at both our local data and compare that to the trials as well as national standards, and this is looking at stage shift. So let me orient you to this table. The blue columns are early stage cancers, so stage 1 and 2, and the orange are the late stage cancers, 3 and 4. And you'll see in the NLST, our ratio is about 55 to about 40. Nelson, they had more early stage cancers. The national average from the SEER 18 group actually is completely flipped. And then you look at RRH, we have a similar to the Nelson. We're actually finding quite a few early stage cancers. We're quite happy with how this local data is looking. All right, so is there a benefit in mortality? Real quick, we see it both in, this is lung cancer mortality, we see it in Nelson, we see it, or in NLST, we see it in Nelson. And then all-cause mortality, only seeing it in NLST. All right, so the patient gets his scan, and he ends up with a result called of lung RADS 4A. The radiologist writes, we recommend a 3-month low-dose CT or a PET. What we see is a 9mm spiculated nodule in the right upper lobe periphery. There's some emphysema on the scan, no lymphadenopathy. The physician plugs this into her probability model, Brock model, and it comes up as a 12.6% risk of malignancy in the next 6 years. So real quick, what is lung RADS and why do we use it? So just as a chart, lung RADS is put out by the American College of Radiology as a management strategy for lung cancer screening. It's based on categories of 1, 2, 3, 4, and then A's, B's, and X is additional feature if it indicates cancer. We consider 1s and 2s a negative study, 3s and 4s and a positive, and it's all based on basically nodule size and growth, and it's broken down by solid and non-solid. So you'll notice, like, for instance, here, a solid nodule, that's the first time we've seen it. If it's less than 4, it's a 2. If it's greater than 6, 2, etc. All right, so does the use of lung RADS improve our accuracy of screening? So this table is basically looking at our test characteristics when looking at use of lung RADS. So Pinsky et al. Shows that in the NLST, that the sensitivity, if you goes down a little bit with the use of lung RADS, but the benefit is that the false positive rate is much lower. So if we're using our NLST definition of a positive nodule, which was just 6 millimeters, and instead use a lung RADS categorization, your false positive rate is about a quarter, both on the initial and the subsequent scans, actually more like a third on the subsequent. And so our positive predictive value is quite a bit better, and there's no loss of our negative predictive value. So when you actually model this, it suggests that you're going to have much less false positive rate. So the patient then goes on to have a PET scan as recommended. The uptake in that nodule is 2.6, no uptake in the mediastinum. We use our Herder calculator, and we realize that this nodule now has a 70% risk of malignancy, and the pulmonologist recommends a biopsy. The patient asks his doctor the following questions. Is this biopsy dangerous, and how good is this hospital at doing these procedures? So it leads us to clinical questions 7 and 8. So what are the harms associated with a nodule workup, and how does RRH outcome data compare to the national trials? So I think most of us recognize the harms of screening, both excess radiation from scans as well as procedures. There's also the psychological and emotional toll of screening, although that hasn't really borne out. So we are very concerned about the false positive rate. So what I'm looking at in this chart is how often do we have false positive results? That's just meaning a lung RADS 3 or 4, and comparing this to the National Lung Screening Trial, Nelson, some VA data, and as well as 31 screening centers that reported, and then local data. And what we see is that that false positive rate is hovering somewhere around 30s, 25, 30%. But at RH, we've done quite well. We're at about 12% for our false positive rate, and I attribute this to our excellent radiology department, who are quite thoughtful in their use of the lung RADs. So kudos, I think, to radiology with this number on our false positive rate. So then looking at complications from procedures, I think most people agree that the most significant complications are those that we see from invasive procedures, people who do not ultimately have a diagnosis of cancer. So we call that the false positive invasive procedure rate, or the false positive complication rate. Again, those are the people who have a workup done for a nodule that ultimately turns out to be a granuloma or infection or just inflammatory. So overall, when we look at the blue columns, the NLST, and the orange are RGH, we'll see that the false positive procedure rate was much higher at NLST, and partly that was they were protocolized for a trial, and here at RRH, each case is individualized, you know, through the work of the radiologist, pulmonologist, and the CT surgery team. So quite a bit lower false positive invasive procedure rate, so I'm quite excited about that. So then you take the next step over to these two columns, and this is the false positive complication rate. And again, our numbers are quite a bit lower than what we saw in the NLST. And then our true positive complication rate, again, is lower. So these are the people who really did have cancer, but they and had a complication in their workup. And I think it's important to note that both in NLST and our local experience is that there's more complications in those patients who actually do have cancer. And I think we tolerate that. And I think the signal here is probably that as docs, we probably recognize that, you know, we have to push harder, and these patients are probably a little bit more fragile. So I think there's a fair amount of intuition that tells us we need to do that workup. So what's next at RRH? We are working hard on developing a lung cancer center of excellence that will span from radiology, pulmonary, CT surgery, oncology. And we're also looking at launching a lung safety net program that will put some safety measures in place for incidental nodules found in radiology. So more to come on that. So back to the case presentation. So following the navigational biopsy revealing adenocarcinoma and VATS, a lobectomy is recommended, and the patient asks his doctor, is this a risky procedure? Are there any alternatives? And having said that, brings us to the next clinical question, or what are the emerging technologies in lung nodule management and diagnosis? And I'll hand off the next slides to Dr. Bhaskar.
While we're switching there, I think we now have 90 participants. So I'm going to do a quick poll just to see who's attending. We can have an idea. So I'm launching the polling now. So please answer which of these describes you best: primary care physician, hospitalist physician, etc. And I'm ending the polling and sharing the results. So as you can see, we have primary care docs, hospitalists, specialty docs, APPs, residents, a whole mix of people. All right, thank you. We'll move on to the next part.
Thanks, Lori. Thanks for having me here today. So I'll be talking about some advanced bronchoscopy approaches for diagnosis and biopsy of these nodules. So it's expected that 1.5 million lung nodules will be detected annually in the US, and even more as we expand our lung cancer screening programs. A significant portion of these nodules turn out to be benign, and the current guidelines therefore advise against whatever is the lowest risk procedure for biopsy if this is indicated. The current guidelines recommend diagnosing, staging, and obtaining material for molecular testing in whatever is the least invasive, and ideally in a single procedure if possible. And they also do recommend rebiopsying for disease progression in some cases, in case there are genomic alterations, and for enrollment in new clinical trials. 80% of these screened nodules are found in the periphery of the lung, which makes it more challenging, at least as a bronchoscopist. And many of these nodules are not ideal candidates for surgical biopsy or sometimes even CT-guided needle biopsy because of the location and or because of emphysema, etc. So I'm going to talk a little bit about the available bronchoscopic approaches. First is grouped under guided bronchoscopy. The two most commonly used modalities here are electromagnetic navigation bronchoscopy, or ENB, and thin or ultra-thin bronchoscopy with use of radio probe ultrasound to locate and biopsy these nodules. So, the second is, I've just lumped them into three different groups. The second is basically guided bronchoscopy with the use of cone beam CT, which very few centers in the country have available right now. Obviously, the radiation risk is higher, but it also seems to be more accurate. The third is up and coming and seems very exciting, robotic bronchoscopy, which again, very few centers have right now. So going to the guided bronchoscopy, the studies have shown increased yields compared to your conventional bronchoscopic approaches, with significantly lower complication rates compared to CT-guided needle biopsy, especially pneumothorax. The other advantage is staging is performed in one setting, and the staging is recommended by the guidelines when the nodules are more than 2 or 3 centimeters in size or central, or if the mediastinum is involved by imaging. However, the yields vary widely between 40 and 70%, and also appears to be lower than a CT-guided needle biopsy for diagnosis. Just kind of going into the two types of guided bronchoscopy. In the bottom part is shown the electromagnetic navigation, where the pathway is mapped by the procedure list, and an electromagnetic probe is guided through the bronchoscope and reached. The lesion is reached with with the pathway. There is no real-time vision in the periphery with this, so the biopsies are blind. However, the lesion is confirmed by fluoroscopy and also use of radio probe ultrasound. And the other procedures in the top half here just shows the use of very thin scopes with the ultrasound probes to localize the lesion. So just going into CT-guided needle biopsy, the diagnostic accuracy has been reported to be higher. It varies between 36 to 84, but the yields are higher if the nodule is malignant, which is interesting. But does have a higher complication rate of up to 15 to 25% risk of pneumothorax, compared to about 1.7 to 7% risk with these bronchoscopies. And also, this may require a subsequent procedure for staging, so this is something that needs to be kept in mind. So again, kind of summarizing the yields, the guided bronchoscopy varies. The addition of cone beam CT to the bronchoscopies may increase the yields to above 80, 85%, but with a substantial increased risk of radiation exposure. But because of the limitations, robotic bronchoscopy has been developed to see if we could overcome some of these challenges. The advantages are some preclinical data has shown that there's more accurate needle penetration into the lesion compared to your other available technology. There's more precise control of movements, the steerability and maneuverability in these sometimes tortuous airways are lessened or improved rather. And it's also stable and can be locked into position. And it's proven to get out even further than your conventional bronchoscopy. There's direct vision, which has never been available in the periphery before. There's also reported higher yields with a eccentric lesion, meaning a lesion that's just to the side of the airway as opposed to at the end of the airway with robotics. And it appears to be safe. So this is just a picture of the scope. As you can see, it's very, looks very maneuverable and very sturdy as well at the same time. And there's direct vision here, allowing for biopsies. The controls are with either a trackball or a joystick. This is one of the platforms shown here. The studies are pretty small at this point, but they are ongoing. The first one is a multicentric study, 54 patients. The diagnostic yield is reported to be 74%, but the criteria, when I looked in there, were very stringent, much more compared to all the other studies for navigation and so on. And also the concentric or the eccentric view yield was much higher compared to what we have available now, 70% versus 30 to 40% now with our available techniques. Another study showed a 93% yield. This is another platform. It just uses a trackball for control, and there's 78%. So just to summarize, we do have available the radial EBUS and electromagnetic navigation right now at RRH. But comparing the robotic versus what's available now, the diagnostic yield, as I mentioned, for eccentric lesions is very exciting because the yields have been low. Even though you're there, the yields are lower because of the orientation, and you're able to visualize in the airway and get more accurate biopsies. So the studies right now are small, but again, they are including more volume as we speak. The sturdiness, vision, and access, I think it's exciting, and I think will have an impact over time when we do these cases. The other advantages are that we could use this for dye marking prior to lung resection and perhaps therapeutics even as the accuracy improves. The challenges, of course, are the upfront costs and any learning curve we would have in learning to do these procedures. So here are some really, I think this is exciting. There are a couple of case reports. So the top left, there's an image of a left upper lobe lesion, which traditionally is very hard, very challenging to biopsy by any modality, other than perhaps surgery. This was accessible, and also material was obtained for molecular testing, which is great, which is what we need. The second lesion in the bottom left was non-diagnostic by both traditional navigational, as well as CT-guided needle, but was able to be reached by robotic bronchoscopy and was proven to be adenocarcinoma. The third one on the right is an eccentric lesion. As you can see, it's to the side of the airway. The radial probe ultrasound confirms this in the sort of top left area of the airway. And because of the visibility and ability to put in your needle out, focusing there, they were able to make this diagnosis of rectal cancer metastasis without need for surgery. So I think in conclusion, the available techniques right now are safe, and the diagnostics and staging can be performed all together in one setting, which saves the patient getting multiple procedures. The yields are lower than the CT-guided biopsies, but they also have a higher complication rate of pneumothorax. And robotic bronchoscopy appears more promising for accuracy and the use. And it may allow for dye marking and use of therapeutics, such as microwave ablation, in folks that can't have surgery or have exhausted their radiation limits for these nodules. And the yields, and all of this could be increased with the availability of cone beam CT for accuracy as well. So with that, I will give it back to Lori. Dr. Liang.
Thank you for having me. This brings to our last part of our talk. The last question is, what are the harms associated with lobar resections for the treatment of early stage lung cancer? And traditionally, lung cancers are treated with lobectomies and pneumonectomies. And they phased out pneumonectomies a decade or two ago after proving that lobectomy have equivalent survival, but less morbidity. And we're seeing a similar trend now going from lobar resections to sublobar resections. So here I listed some of the reasons why the lobar resections do have significant morbidities and mortality for patients. There's significant amount of reduction in lung function. So when we take out a lung nodule or lung cancer, it's not just digging out the lung nodule. We often have to take surrounding normal tissue. And the margin, the gross margin, is usually at least equal or greater to the diameter of the tumor. So this ranges from losing 11% to 28% for various parts of the lobectomy that you will do. And the hilar dissection, the fissure dissection, a lot of lung surgeons may not know that they actually make your future lung resections very, very difficult and gives you a higher risk of intraoperative bleeding and complications. There's also extensive scar tissue and adhesion formations later on. And there's also a non-zero perioperative mortality rate. So even with the best care, 1.3% of patients will die. This is usually from intraoperative complications, post-op MI, stroke, DVT, PEs. And the morbidity, also the rate is very high. And at some places, they quote 15 to 32%. So these can range between prolonged air leak, AFib, and that's respiratory failure, et cetera. And because of these complications, if the patients develop future lung cancers and lung nodules, and they may not be a candidate for curative resections. So over the next few minutes, I'll go over some of the topics in newer surgical treatments for lung cancer. So this includes the lung adenocarcinoma spectrum, the stages of prevention, issue of overdiagnosis, overtreatment that we touched on prior, and how to avoid overtreatment. So this is the lung adenocarcinoma spectrum. There used to be a term called bronchoalveolar carcinoma. What it means is basically a specific growth pattern of the cancer cells. So within non-small cell lung cancer, there are many different histologic types. And specifically for lipidic pattern, it tends to go along the structures. And in some cases, they don't invade the basement membrane. And radiographically, they appear as ground glass opacities. And this is an example of ground glass opacity where it's like a haziness, but then you can still see the bronchovascular structure through it. And why do we care about lipidic pattern? Lipidic pattern is actually a good prognostic feature of a tumor. So if we know that the tumor is predominantly lipidic, then the risk of cumulative incidence of recurrence is 0. And as you go down the spectrum, so if you have less lipidic pattern, risk of recurrence goes up. If it's less than 10%, it's 22% local recurrence. So this shows that when you have these kind of early stage, either in situ or minimally invasive adenocarcinoma with lipidic pattern, you can achieve a 0 recurrence rate in the next 5 years. And the specific spectrum, usually we require experienced pathologist to review, but basically goes from AAH to in situ to minimally invasive to invasive adenocarcinoma. So the previous term of bronchoalveolar carcinoma that encompasses all of this have been replaced with this more detailed and clear distinction between pre-invasive, minimally invasive, and invasive adenocarcinomas. And these tumors, radiographically, they appear as ground glass opacities. And studies have found that if you have ground glass opacity, and if they persist or they grow bigger, 75 to 85% of them turn out to be somewhere on the spectrum. And tying it in with stages of prevention that we're all familiar with, so in terms of lung cancer, a primary prevention would be smoking cessation before you have any evidence of disease or cancer. And secondary prevention is where I think the lung cancer screening and also the curative resections are, is before the disease becomes symptomatic. And with higher stage disease, then the tertiary prevention predominantly aims at reducing complications. So I think with lung cancer screening, we can get a lot of work done in terms of secondary prevention. And so these are GGOs detected on lung cancer screening. Patients are asymptomatic, and the treatment is curative intent. And many studies and over have shown that for these pre-invasive and early stage cancers, the 5-year survival and disease-free survival approach is 100%. We did go over some of the diagnosis issues in terms of false positive results. So the studies in the NLST quoted 23.3%. And the issue with overdiagnosis, especially for the early stage lung cancer, is that these cancers are so slow growing that they don't cause immediate harm. So when the patient receives a diagnosis, they think, oh, I gotta have surgery next week. But we have shown that you can actually wait. So for example, if somebody's, oh, I'm going to delay my wedding for this surgery, that's okay, have the wedding, have the surgery after. So that's really a paradigm shift in treating these early stage lung cancer, that you don't want to put away some of the important social and career events in life to undergo surgery, because it's not considered urgent that it has to happen tomorrow. And another thing is some people ask, okay, a lot of these things can be found at the time of autopsy. So for example, prostate cancer screening has increased number of new cases, but deaths remain the same. Is that the same for these early stage lung cancer? I think in Laurie's talk, we showed that even though you don't see a difference in 5 years, in 10 years, in 11 years, we are starting to see the difference. And another issue with overdiagnosis is that in some of these trials, a lot of procedures are done for benign diseases. I think it's good to sometimes catch a small number of benign diseases so that you have a low rate of missing the malignant. But for example, in NLST study, 30% of the resected nodules were benign. I think we did a better job at RAH system. And the reason is any lung operation is major operation. Doesn't matter you do a wedge or lobectomy or segmentectomy or pneumonectomy. Every patient has to go through a full general anesthesia with invasive monitor with art lines and central lines. And for the entire duration of the procedure, they're breathing on one lung. And there's, as we said, there's significant loss of lung parenchyma. And the post-op pain, it's an issue that I think a lot of people may not be aware that these people can have debilitating chronic neuropathic pain because there's no other way to access the chest except in between the ribs. And that's all your nerves, all your ribs run in the intercostal space. So a lot of people do have chronic neuropathic pain. And the 30-day mortality ranges. This depends on the extent of resection and also the baseline patient characteristics. So what is the definition of overtreatment? So some of them, overtreatment is a result of unrecognized overdiagnosis, as we said, doing a major operation for benign disease. Another type of overtreatment is for these early disease, you don't need to take out the big guns in terms of surgically. So these slow-growing tumors, a lot of them are found in the autopsy studies, and not all of them progress. So this is kind of like colon cancer. Not all the polyps eventually grow into cancer. So I think it's wrong to treat these kind of polyps equivalent lesions as if they were cancer. So there's an equivalent in lung cancer surgical treatment as well. And I think the principles we adhere to is early does not equal to late, and indolent does not equal to aggressive. So we need to tailor the surgical treatment based on the tumor characteristics. So pre-invasive lesions, we advocate that they should be treated with wedge resections or segmentectomies. And later on, I'll show you pictures of what it means to be wedge resection or segmentectomy anatomically. And for these early stage pre-invasive lesions, it's best to avoid lobectomy because of all the complications listed above. And avoid hilar dissection, avoid full mediastinal lymph node. All of the reason for all of this is that if you resect less lung now and you cause less scar tissue now, 10 years down the road when the patient develops another nodule, another cancer, you don't burn bridges for these patients. And especially our patients are living longer, you're screening them earlier, chances are many of these people will have a second primary. So usually in most studies, the rate of second primary in the same patient is about 2.5% per year. So a lot of these people, as they're living longer, you will start seeing them developing new nodules and new cancers. So we don't want to burn all their curative treatment bridges from the beginning when they're in their 50s. So here is a demonstration of different anatomic resections. So traditionally, you can do a pneumonectomy, which is you take out the entire lung on each side. And now for basically regular lung cancer, we will do a lobectomy, meaning this is right upper lobe, right middle lobe, right lower lobe. These have to be taken en bloc. So you can't just dig out a little nodule within the parenchyma. That's actually not curative. For the early stage lung cancers, what we advocate for is called segmentectomy. So for example, you see that in your right lung and left lung, you have 5 lobes. You divide the 5 lobes into 18 segments. So you can see that you lose significantly less parenchyma with a segmentectomy compared to a lobe. For example, within the right upper lobe, you can split it into 3 segments. Right lower lobe, it's not all the lobes are shown, but you can split it into 5 segments. So by splitting it, you're resecting less parenchyma. And also, pathology and autopsy studies have shown that these segments function as little mini lobes. So if you take the segment and all the lymph node drainage, the bronchus and its segmental arteries and veins, it's also an oncologically sound resection because you're taking all the lymph node basin lymphovascular structure within that segment. So it is considered an oncologic operation. And we do have our surgical robot, the Da Vinci Xi, which facilitate predominantly the segmentectomies. And our system does the most number of segments for early stage lung cancer in the city so far. So this is a picture reminding you that no lung operation is minor operation. These are all big structures that we work with. And so any minimally invasive technique has a conversion rate to open. We called it around 5%. So if you get into any of these big vessels, sometimes you can maybe fix it minimally invasively. But if you do most of the time, you would have to convert to a thoracotomy. This is just another picture of showing, it doesn't matter you do a segment or a lobe, you're working with these big bronchovascular structures, and there is a risk of conversion and intraoperative complication leading to potential mortality. So there's the other thing called non-anatomic resections. These are wedges. What we sometimes will do a little wedge for is if you have a nodule, you can't get a good diagnosis by biopsy. Sometimes we would do a wedge biopsy during the OR. We would send it for frozen section. If it comes by cancer, then we go back and do our anatomic resection, which is the cancer operation. But if the frozen section says, oh, looks like granuloma, then we'll just leave it the way it is. The benefit of doing a wedge biopsy like that is you get the whole nodule in your specimen. And another thing is that it doesn't involve any hilar dissection, so you don't go into any of the bronchovascular big structures at the hilum. So later on, when the patient, if they ever need another procedure, it's relative like a virgin chest that it will make your next operation harder. And here is the rationale that not everyone needs a mediastinal lymph node metastases. So time after time, we have shown that mediastinal lymph node dissection is more for prognosis, not for any kind of a disease treatment. So for these early stage lung cancers here, it's kind of small font labeled AIS, MIA, LPA, so lipidic growth. So for these tumors, you notice that there's almost no N2 disease in the lymph nodes, whereas for every other growth patterns, there's always some risk of lymph node metastases. So this is the rationale that for these early stage lung cancer, you don't need to go into the hilum or the dangerous areas to dig out all these lymph nodes. And after resection, what we recommend is usually 5 years of surveillance CTs. And if somebody gets their resection of a nodule or a early stage lung cancer in their 50s, that's a lot of CT scan for a young person. And studies have shown that if you do CT scans in a young person, say in their 40s and 50s versus CT scan in their 80s, the risk of cancer is much higher if the CT scans happen for the earlier age group. And just to put things into perspective, your cosmic background radiation is 0.3 millisieverts per person. Each chest X-ray is less than that, 0.1. But when you do a CT chest with PE protocol, that's equivalent to 150 chest X-ray. So imagine somebody has to come in every 3 months, every 6 months to get that amount of radiation. And that's quite significant added up over the years for a young person. So in summary, we went over the lung adenocarcinoma spectrum. We said this is mostly secondary prevention. So we're trying to treat the cancer with curative intent. And in terms of the issues of overdiagnosis, overtreatment, we stick to our principle that early disease should not be treated as late disease, and indolent disease should not be treated as aggressive disease. And we do have methods that we can avoid overtreatment in these pre-invasive and minimally invasive lung cancers in terms of sublobar resection, avoiding mediastinal lymph node dissection, and reducing imaging surveillance after surgery.
Okay, great. I guess we can open it up for some questions. Dr. Lerner, you've been running this clinic for lung cancer screening. Are people sending you a lot of patients, or are they tending to do the screenings themselves, or how's that going?
What we're seeing right now is about 60 to 70% of the lung cancer screening done in RRH is through lung cancer screening program, and the other 30 to 40 is being done by either the pulmonologist or the primary care docs.
A question that came up on the chat box was, when does TB enter the differential for a nodule?
When does TB, tuberculosis, enter the differential?
Yes.
Let's see. TB can always be on the differential. That's what we've learned in risk factors, exposure. If it's ever a cavitary nodule. Jayshree, you want to jump in? Upper lobe or in the upper superior segment of the lower lobes.
What proportion of the nodules that you wind up biopsying turn out to be malignant?
No, what portion of the nodules turn out to be malignant? So going back to our slides, let's see. I get back to this. Looking at our false positive intervention rate was only in the single-digit numbers, so we're actually doing a pretty good job not biopsying negative lesions. So our numbers are pretty good, and I think that speaks to our practice pattern here. One, using the lung rads, we're already getting less positive results on our CT scans. And then we have a multidisciplinary approach to discussing these nodules that might be in question. And then also the practice pattern has been to use these risk models, which would be the Brock model, which came out of Canada, actually formally doing a risk assessment based on patient risk factors, which include history of malignancy, family history of lung cancer, age, location in the chest, size of the nodule, and age. And so those have been quite useful tools, I think.
Yeah. It's actually interesting, you guys have, since you started this program, you've changed our profile of diagnoses of stages of lung cancer. So look at our tumor registry. Most of our lung cancers were stage 3 and 4 before. Now, since we're doing all this screening, many of our lung cancers are stage 1 and 2. So I hope that reflects that we're just diagnosing the same cancers earlier and fixing them. But some of this could also just be an ascertainment bias, and we're picking up some early stage lung cancers that may never have caused a problem, right?
Right. Yeah, I'm not sure we'll ever know without a control group, but based on the studies, there is overdiagnosis, and I don't think we can avoid that. I think the folks that are early in screening that cancer is probably more likely to be an overdiagnosis. Later in screening, I suspect those are probably less likely to be an overdiagnosis cancer.
Opacities versus more solid appearing early stage.
I'm not seeing any other questions, so you must have done a good job answering everything with your presentations. I mean, it's great to see the new surgical techniques. That's amazing that you can do these things with a robot and leave so much of the lung intact. So that makes this even more attractive than it used to be. Yeah. Do we have access to the robotic bronchoscopy at this point, or is it coming soon?
So we are in the process, and hopefully we will acquire it soon.
We've asked, please.
Yeah.
The emphasis on this talk is, in reflecting back on when I first gave a talk on lung cancer screening, and even when we first set up the program, I think the concern, and justifiable, had been adverse events from lung cancer screening, because we find so many nodules, and this idea that there's so many false positives. And I think that idea has really become refined in the literature to understanding that false positives just as far as a false positive scan are not the real harms. The real harms are in false positive evaluations. And so, you know, as an organization, we've really been trying to focus on ways to refine our diagnostic techniques to limit harms, and focusing on non-invasive technologies, and also, you know, focusing our surgical techniques on these sublobar resections and minimally invasive interventions.
Great. Well, I want to remind folks that they should send in their evaluation forms if they want to get CME credit for this. And I think with that, we'll see you next week for Grand Rounds. Thank you all very much. Great presentation.
Thank you.
Thank you.
Thank you.